Hello, I'm Dr. Kim Young-jin. In the last lecture, we talked about resorbable barrier membrane, and this time we are going to talk about the non-resorbable membrane. The non-resorbable membrane has very good benefit of maintaining the volume, but it is a little bit burdensome in terms of the prices. Clinicians do not really prefer to use it because it is hard to handle, and it should be removed recurring one more surgery. However, sometimes we have to use the non-resorbable membrane for better clinical prognosis. Let me show you my cases, how to use it easily and stably and successfully in this lecture. First, I would like to talk about the properties of the non-resorbable membrane and also the downsides of it. Clinical technical tip to overcome the downside will be shared, and I will show you my cases how to use it clinically. First, as I told you in the first lecture, there are two types of membrane. Today, I'm going to talk about the non-resorbable membrane. Non-resorbable membrane uses one material, polytetrafluoroethylene, which is synthetic resin. Depending on how it is treated, there are two types, whether it is expanded or non-expanded. Expanded PTFE membrane and non-expanded PTFE membrane. First, Gore-Tex, the expanded PTFE membrane is expanded suddenly, about 800%. Because of that, fibrins are expanded. Between them, pores are created in the size of about 5 micron. It is known as the brand name Gore-Tex. So PTFE membrane uses the same material, but how it is treated, like whether it is expanded or not, the pore size would be different. When it is expanded, the pore size would be about 5 microns. If not, the dense PTFE membrane has less than 0.3 micron pores. Because of that, the expanded PTFE Gore-Tex, once it is exposed, oral bacteria can enter into the GBR site or penetrate into it through the pores. However, the non-expanded PTFE membrane has the pore size which is smaller than the oral bacteria. Even though it is exposed, the bacterial migration is not allowed. Therefore, for clinicians who would prefer DPTFE much more. To recap, EPTFE, called Gore-Tex, has the pore size of about 5 micron. However, cytoplast DPTFE membrane has the pore size of less than 0.3 micrometers. So if you consider the bacterial size present in the mouth, an open membrane technique can be used. That means even though the membrane is exposed, bacteria cannot penetrate into the membrane when you use MPTFE membrane, that is DPTFE membrane. However, there's no problem. Gore-Tex EPTFE membrane is no longer produced by the manufacturer due to this kind of clinical problems. Many dentists migrated to DPTFE membrane, so it is no longer produced. As DPTFE membrane has small pore size, even though it is exposed, bacteria colonization cannot occur inside, even though it can occur outside of the membrane. In other words, even though it is exposed, bone regeneration can be stably achieved. It is advertised, emphasizing that complete primary closure is not needed. Another characteristics of that is that, unlike the collagen membrane, DPTFE membrane is very rigid. It has rigidity and elasticity. As it is rigid, it is indicated for alveolar bone augmentation. When horizontal or vertical bone augmentation is needed, the rigid DPTFE membrane can be used to maintain the space. When implant is placed outside the bone envelope, this can be indicated. As I said before, when an implant is placed outside the bone envelope, overall alveolar bone form is reduced and it should be improved so that ideal alveolar bone contour can be created around the exposed implant. So a rigid membrane is required. However, many clinicians do not like to use the DPTFE due to elasticity and rigidity. It is hard to adapt the membrane. A collagen membrane can attach and adapt to any defect and it doesn't require fixation. However, DPTFE membrane cannot be hydrated, so adaptation is difficult. Another thing, even the pore size is small, less than 0.3 micrometer, the margin of the membrane can be exposed through the flap. Then bacterial migration can occur through the margin, leading to infection inferior of the membrane and the poor bone regeneration. If the center of the membrane, not the margin, is exposed, bacterial migration is not allowed. However, in many cases, the margin can be exposed. Even though with good primary closure, problems can occur later. Therefore, I can say this, DPTFE membrane, when you use it, unintentional, unexpected exposure should be prevented, especially in early wound healing, it should not be exposed. And we need to consider several things for that. A very good paper. Let me introduce it briefly. Flap advancement technique. How much you advance the flap can be a factor. First, minor flap advancement 2 to 3 millimeters or moderate flap advancement of 3 to 6 millimeters or a major flap advancement bigger than 7 millimeters. The advancement technique can differ. As I said before, the PTFE membrane is indicated when you need to augment the volume of overall alveolar bone, where soft tissue primary closure is difficult, so buccal flap should be advanced coronally to make the tension-free primary closure. So when you use a PTFE membrane, moderate or major flap advancement is required. So the flap advancement of 3 to 6 millimeters or more. For a minor flap advancement of 2 to 3 millimeters, a vertical incision is not required. Extend the circular incision up to 1 or 2 adjacent teeth. If you raise the buccal flap beyond the vestibule, the flap can be advanced 2 to 3 millimeters. But if you use PTFE membrane, in many cases, the primary closure using this technique is not possible. With the PTFE membrane, moderate flap advancement is required. Then, 2 vertical incisions should be made. Inside the buccal flap, the dense connective tissue periosteum's continuity should be severed by creating a periosteal releasing incision. If you need even further advancement, in the same way, you need to make a periosteal incision. The submucosal layer below it should be dissected bluntly. Submucosal layer should be severed, or periosteal elevator should be used for the blunt dissection. That is what is known. So periosteal releasing incision is very important. Periosteum, the dense connective tissue inside the buccal flap, should be cut so that outside loose connective tissue, the oral mucosa extension can be made. If you look at this clinical case, the periosteum is cut off. The outer oral mucosa extension is opening up. The buccal flap is extended coronally 6 to 7 millimeters. One more important thing is to close the flap. Buccal flap should be extended coronally, and for tension-free primary closure, horizontal matrix suture should be used. The advantage of horizontal matrix suture is with the wide surface contact, the buccal flap and lingual flap can be inverted. Suturing, horizontal matrix suture, and simple interrupted suture should be appropriately used so that overall incision line can be inverted. Up to now, I have talked about the flap management and closure. As I said before, PTFE membrane is very rigid and elastic, so adaptation of it is very difficult. Then how can we adapt the PTFE membrane so that it can cover the bone graft below? First, suturing. Membrane holding suturing can be used to press it down. It starts at the lingual or palatal flap and partially penetrates into the periosteum apical of the buccal flap and goes to the lingual or palatal to make a knot. So the purpose of using the membrane holding suture is to press down the PTFE membrane, which is rigid, to prevent membrane exposure and increase adaptation of it. Another way is using a pin. It is called a bone tack. Micropin is used to fix it. GBR kit is launched by Austin. Very good quality bone tacks are available. Bone tacks are fixed using the bone tack holder malleting. Then very elastic PTFE membrane can be adapted. First, it is fixed on the apical side first, and it is raised, and bone graft is done. Using the membrane holding suture below the incision line, adaptation can be done. Let me show you a case how to apply it clinically. A 67-year-old female patient for fixed prosthesis on the upper jaw supported by implant. The patient was referred to our hospital. The sinus floor is traced. The distance to the sinus floor is measured about 4 or 5 millimeters. Crystal approach is also planned. Pre-op photo. This is a occlusal view. In terms of the bone, many of you may think the bone width is quite good in this case, but this is a flabby tissue, a combination syndrome. If you have a fixed prosthesis in the mandible removable on the maxilla, then flabby tissue is formed on the upper anterior. If you open it, it looks like this. Let's compare. The soft tissue is there. On a occlusal view, when the flap is opened, the occlusal view, the soft tissue outside looks like it has bone beneath it. So you need to enter after measuring the bone width using CT. First, the alveolar ridge crest. The residual crest is irregular and very thin, which can make initial drill slip. To stabilize the initial drill, we need to flatten the alveolar bone. I use the crest remover in the asset kit. Crest remover for straight handpiece is used to flatten the alveolar bone to prevent the slipping of the initial drill. After the flattening, first, at the upper posterior, crystal approach is used for the sinus lifting using the CAS kit. It is hydro-lifted and the bone graft is performed. For the premolar and anterior region, taper kit is used for the drilling and the 7 implants are placed. As you can see, the implants placed in the anterior region and premolar area, the buccal side is exposed because of the severe horizontal bone loss, then which membrane should be used? As the implants are placed outside the bony envelope, the alveolar bone appearance needs to be augmented horizontally, so a rigid non-resorbable membrane should be used to maintain the space. And in this patient, we need to use a removable RPD for temporary, a removable partial denture. So the compression from the temporaries should be resisted, so a rigid non-resorbable membrane is decided. First, the cortical perforation is made to induce bleeding from the bone marrow. Using PTFE membrane, when we do GBR, we do the periosteal releasing incision first. If we make the incision after the bone graft covered with a membrane, we do not know where to make the incision. Also, when we make the releasing incision to cut off the periosteum, really it bleeds. Because of the bleeding, the bone graft materials below can go all over the place, so I make the periosteal releasing incision first and check how much advancement of the flap can be made before GBR. After checking the released amount after making the incision, 2 bone tacks are used to fix the apical side of the membrane. After that, around the implant, autogenous bone outside xenograft is used using a sandwich technique. On the right, in the same fashion, the apical side is fixed with the 2 bone tacks, autogenous bone near the implants and xenograft on the outside are applied. The apical side is fixed, but it was hard to adapt the membrane under the incision line. Using a membrane holding suture, the coronal, the upper side of the membrane is pressed down. Thanks to the periosteal releasing incision made before, tension-free primary closure was easily achieved. So the primary closure of the flap is achieved using horizontal matrix suture and simple interrupted suture. So the wound, the incision line is everted using the suture. Post-op panorama. Post-op 5 months, the second stage of surgery was done. The soft tissue healing was very good. The membrane is not exposed. PTFE membrane, as long as it is not exposed, the bone below is fantastic. After 5 months, the incision is made and the flap is raised to remove the membrane. The membrane is removed and we can see very good formation of bone on the right as well. And the cover screw is changed to healing abutment. And around the healing abutment, the primary closure was achieved, completing the second stage of surgery. The rigid PTFE membrane is used, and the horizontal bone augmentation was achieved around the implant. Occlusal view, ideal bone contour is created around the exposed implants. Summary: PTFE non-resorbable membrane. There are 3 important things. You need to trim it pretty well. Trimming is very important. In the case of collagen membrane, even though trimming is not done properly, mostly it is not exposed even though it is near the incision line. However, the PTFE membrane, the proximal margin is very close to the vertical incision line. In many cases, they get exposed. So you need to have 2 millimeter safety margin between the vertical incision and the membrane's proximal margin. When you trim the membrane, you need to do it using a template. It should be a little bit bigger than the template when you cut the membrane, so that the membrane can be adapted to the augmented volume after the bone graft is done. All the margins of a membrane, apical, proximal, lingual, and palatal margins should be positioned on a sound bone. To completely cover the bone graft material below, just like when you make a dumpling, you need to contain completely the bone graft material below the membrane. That is to maximize the stabilization of a bone graft material and for stable bone regeneration. So all the margins of the membrane should cover at least 2 millimeters of sound bone. As I said before, the proximal margin should have at least 2 millimeters of distance from the vertical incision line. It also should have at least 2 millimeters of safety margin from adjacent teeth or adjacent implant healing abutment to prevent its exposure that can lead to infection. When we apply the membrane to a patient with such defect, the PTFE membrane, we need to design it to cover at least 2 millimeters of sound bone, and it should be 2 millimeters from the residual teeth. So we need to be more careful when we use a non-resorbable membrane compared to a resorbable one. We need to be careful in trimming and in fixing it. One more thing, when it is exposed, the open membrane technique can be used. Even so, the margin of the membrane should be within the gingiva. The prognosis is very poor once the margin is exposed. We should be very careful so the proximal margin is not exposed at all. When we actually place an implant, we encounter various clinical environments, and bone defect is one of those that we encounter frequently. So we need to provide bone support around the implant to minimize complications and to increase long-term prognosis. That is the first step toward successful implant procedure. For proper bone support, we use GBR procedure often. For successful GBR, membrane selection is important. I hope you would make very wise and reasonable decisions in that regard. This concludes the lecture. Thank you very much for your attention.